As a child between the age of 6 and 14, I recall frequent bedwetting occurrences. I can still recall the embarrassment associated with having an accident while on a sleepout at a friend's house. I remember having an accident while sleeping in our backyard treehouse. I remember my trying to stay awake all night just so an accident would not occur. During this period of time, I refused to participate in Cub Scout sleepovers and campouts. I would rather miss the fun than experience the terrible embarrassment. These memories were relived when my two children had similar problems. While pursuing my formal professional education at Logan College of Chiropractic in 1978, I had the opportunity to visit with a chiropractor who had some 30 years practice experience. I don't recall who brought up the subject, but we soon found that this fine doctor had some important things to say about the problem of bedwetting. The chiropractor suggested I try specific spinal adjustments combined with specific relaxation exercise routines on my children. This chiropractor readily explained his theory of what he believed was the cause of most bedwetting problems. At first I was skeptical about what I had learned, but soon reasoned there would be no harm in trying the concept with my own children. To my pleasant surprise, the initial treatments on my children produced amazing results. After graduation and starting practice, having been encouraged with my success, I began to develop the treatment procedures. After a few years, I was able to refine and, more importantly, simplify the procedures. This enabled the relaxation technique to be performed by the child's parents on a nightly schedule. During my early years in practice, I was extremely careful about telling anyone about the anti-bedwetting successes. I certainly did not advertise my success. How could I scientifically defend what I was doing? All I knew was that what I was teaching the parents was working. As a result, I've always been extremely selective who received the benefits of this technique. What I will teach you in this next 20 minutes will be a safe, simple, rewarding procedure. I'm confident you can grasp the technique only after a few attempts. Most scientific dictionaries or research texts tend to agree on the definition with only slight variation. The medical term for bedwetting is earnesis, defined as a common habit disturbance characterized by repeated, inappropriate, and involuntary passage of urine. More simply, earnesis is defined as the involuntary discharge of urine. Categories may be classified as primary nocturnal earnesis, when it is always present without any dry interval. Secondary nocturnal earnesis, when the onset has come after a prolonged period of nocturnal dryness, usually after 6 months. Diurnal daytime wetting, urgency incontinence, or psychogenic deliberate or direct pathology is not covered under the scope of this video. Other warnings: involuntary and consistent bedwetting during sleep by a child over 5 or 6 years is abnormal and may be a sign of severe underlying pathological changes. Other facts. Available literature states by the age 4.5 years, 88% of children have ceased bedwetting. By age 7.5 years, 93% have ceased bedwetting. There are over 7 million bedwetters in the United States. Bedwetting is 2 to 3 times more prevalent in males than females. One distinguished medical text states more than 75% of nighttime bedwetters have a small bladder capacity. 20% have normal-sized capacities. Normal bladder capacity is approximately 1 ounce per year of age plus 2, or 10 milliliters per kilogram of body weight. During my 20 years of practice and study, I have not found acceptable scientific literature to explain the predominance of male over female. I do have my own theory, but I will reference this as we progress through this video. Psychological factors and considerations. I have never found a child that has denied the embarrassment of this problem. I've never found a parent who did not express almost total frustration with this problem. I can tell you that the ramifications of embarrassment is far greater for the child than for the parent. Children who experience bedwetting endure a great deal of embarrassment from their peers, siblings, relatives, and parents. I will assume that since you are viewing this video, you are a parent or guardian of a child with a bedwetting problem. First and foremost, I urge parents to develop a trusting, supportive relationship with their child. Parental scolding and conveying a guilt complex is not in the child's best interest. Parents must also discourage punitive attitudes by caretakers and self-blame by the child. A parent with a ridicule, scolding, or punishment-oriented attitude will only aggravate the child's bedwetting problems. Let's take a look at the anatomy of the urinary bladder. The bladder lies in the pelvis, anterior and inferior to the peritoneal cavity, and posterior to the pubic bones. In the female, it rests directly on the muscular pelvic floor. In the male, the prostate gland is attached directly to the base of the bladder and separates it from its muscular support. Micturition. Urinary reflex micturition is the process by which the urinary bladder empties itself when it becomes filled. How it works. The bladder progressively fills until the tension in its walls rise above a threshold value, at which time a nervous reflex called the micturition reflex is elicited, which greatly exacerbates the pressure in the bladder and simultaneously causes a conscious desire to urinate. The micturition reflex also initiates appropriate signals from the nervous system to relax the external sphincter of the bladder, thereby allowing urination, called micturition. During sleep, there is no conscious desire to urinate. It is automatic and uncontrolled. The medical examination. This important exam may be performed by a family practitioner, a pediatrician, or a specialist such as a urologist. You must take your child for an examination to be absolutely certain there are no organic problems causing the abnormal bedwetting. Common problems are kidney or bladder infections, diabetes insipidus, water retention handling problems, diabetes mellitus, which are sugar handling problems, extreme fatigue, bladder constriction and spasm, underdevelopment of the kidney and or bladder, micturition delay pathology, sleepwalking, common habit disorders, and a host of other problems. Most family physicians will perform a simple physical exam, including a urinalysis. If no pathology is found at this point, no further diagnostic studies are usually necessary. The chiropractic examination. A chiropractor should perform a spinal examination to assess the possibility of disturbances known as spinal subluxations or fixations. The chiropractor may order X-ray studies. Hematology and or urine testing should be completed if not already performed by the child's family physician. Subluxations or fixations. In the cervical spine, subluxations or fixations can be responsible for sleep disturbances, hyperactivity, extreme fatigue. Thoracic subluxation or fixations can be responsible for limiting nocturnal respiration, creating imbalances in the acid-alkaline ratio. Lumbar subluxation or fixation can easily inhibit or excite the nerves controlling the kidneys, uterus, bladder, etc. I have 3 theories which I base the success of my anti-bedwetting technique. Theory 1. Bladder compression or spasm. Imagine the child's bladder has a volume approximately the same as a large lemon or tennis ball. Consider it a soft elastic rubber ball which is a muscle having the ability to fully contract or compress, squeezing out any fluid contained inside. The bladder remains in spasm, fully contracted, thereby preventing any volume of urine to be stored. Several causes of spasm. The micturition response causes this tiny volume ball to compress when it is time to urinate via the brainwaves. One can see there is not much room to hold urine. The bladder remains this way when spasm exists, leaving virtually no room to hold urine cleared by the kidney. Although there is no simple method of measuring or assessing this occurrence, it remains the most logical factor in view of the fact that the treatment is so successful. Theory 2. Children, especially boys, are extremely physical. They play rough, running, jumping, falling, tumbling, etc. As a result of this physical activity, the child experiences a subluxation or fixation. Microtraumas occurring in the spine. These are specific places in the spine which are fixated or stuck. When this occurs in the low back area, the entire urinary tract can be affected via the efferent and afferent nerve tracts. When this subluxation or fixation occurs in the mid-back or thoracic area, there can be again a problem with the nerve tracts in and out. Additionally, there can be fixations at the rib junctions, preventing full inspiration and full expiration. My theory is that there exists a gradual change in systemic pH levels resulting from a restricted respiration. This can and most likely cause the brain to execute the micturition response. Theory 3. Children, especially boys, play exceptionally hard. At bedtime, they are physically exhausted. This allows them to fall into a deep sleep. Some groups who study the bedwetting problem believe this deep sleep is the prime cause of bedwetting. I apply all three theories in my anti-bedwetting technique. The application is extremely rewarding. A. Weekly spinal adjustments to remove microtraumas, subluxations, and fixations in the spine. B. Relaxation stretching techniques at bedtime, which I will demonstrate, are designed to relax the body muscles, develop smooth, uninhibited respiration, allowing proper regulation of the pH levels. Spinal massage techniques applied to the low back will relax and release tension, anxieties. C. The pressure release procedure performed over the bladder is designed to relax and to reinflate the spasmodic contracted bladder. D. Habit modification, improve emotional relationships, allow nightly frequent visit to the toilet. Reward for child performance, child's own alarm. Treatment and parental involvement. Before progressing to the actual treatment, I urge all parents to check with your family medical and chiropractic physicians. Their role is to ensure there are no hidden pathologies which require intervention. This cannot be overstated. Available treatments. There are several choices offered. Responsibility training, which promote active involvement. Positive reinforcement for desired behavior. Sleep disorder therapy. Use of electric alarm devices and or moisture devices. Oversized diapers. Pharmacologic treatment. And now, the anti-bedwetting technique by Dr. Rick Sheldon. General consensus among the medical community. Evidence for the cause of earnesis is not fully understood. There is no known effective method of prevention. Evidence for all of these treatment methods is divided and inconclusive. The natural history of bedwetting is spontaneous resolution in almost all cases by age 18. I was fortunate and I stopped by age 14.